you carry a piece of the most wonderful person on this planet in your face. Oh, doctor, I never thought about it like that. That is a new thought. And I said, well, then why not reflect on if we basically improve the shape of your nose, but we respect the love of your grandmother and the specific shape you have.
Ladies and gentlemen, welcome to another episode of the Rhinoplasty Podcast with me, Dr. Cameron McIntosh. It's the month of April, and we're continuing about endonasal rhinoplasty. It's a huge shout out to Marina Medical for enabling the April Endonasal Rhinoplasty Podcast. Thank you for supporting us. Now, on the show today, I've got a very interesting man, all the way from the canton of St. Gallen in Switzerland. One of the most professional people I've come across at all the conferences and stuff, how he presents himself, how passionate he is about rhinoplasty in general, but especially endonasal and passionate about teaching. So it's with great pleasure that I welcome Abel-Jan Tasman to the show. Abel-Jan, thank you for being with us today.
Very welcome.
So for our listeners, around the world, tell us a little bit more about Switzerland and what you do there and how you ended up becoming a rhinoplasty surgeon.
Well, if you want to start with Switzerland, beautiful country, full of snow at the moment, perfect slopes, nice sunny weekends. Just spent 2 days cross-country skiing and downhill skiing. It's a nice place to live. Many people are relatively satisfied, especially the doctors complain less than in other countries. I don't fully understand why that is so, but that's one of the reasons why I came to this beautiful country. Having specialized in facial plastic surgery early on in my ENT career. Basically, as a last year resident, I was allowed to do procedures that really caught me and motivated me to continue this. And I started out indeed as an endonasal rhinoplasty surgeon, then tried the open approach, but quickly came back to the endonasal for basically the elegance and the technical challenge, I would say. Mm.
And at the moment, are you in a full-time academic post, or do you also do private medicine?
No, I have a very appealing appointment at one of the largest non-university hospitals that is becoming academic now in the eastern part of Switzerland, not too far from Lake Constance and the Austrian border. Pleasant working, but I'm expected to work full-time in the hospital, which I'm very glad to do. So I don't have a private practice, or you could say I have a private practice within the hospital. Okay. So I have my private patients and my own secretary.
Oh, that's great. And now you like your cross-country skiing in winter. What do you get up to in summer when you're not working?
Well, I like to hunt. I like to hike, mountain tours, and we have an old wooden sailing boat on the lake, so I'm a very outdoorsy person, like the water, like the mountains.
That's awesome. Okay, so my first question to you, I want to get around that semantics of this whole thing about endonasal rhinoplasty and open approach and structural and preservation rhinoplasty, because there's a lot of hot air out there. There's a lot of self-promotion, I think. Say some of your thoughts around that, please.
Well, I agree. I think there's a lot of the terminology is ambiguous and is not very clear. Let's, for instance, start with the term preservation. Preserving means respecting, and that's what I do. I don't do preservation as it is taught and seen in many courses. I have quite a large series of patients where I did a classic let or push down technique that was described in the 1950s. In the US by Kotler, as far as I know, and then by Bert Heusing in Europe in the 70s, it was 75. It was something that was belittled when I was a resident and a fellow, because that was the time when humps were resected. There was aggressive cartilage modification of the alar cartilage, so it was basically ablative. And the whole concept of leaving the dorsum alone was very last year. It was very outdated and out of fashion. And I came to understand that there is a lot to the concept. Now, I wouldn't call it preservation per se, because you don't preserve everything. To me, preservation is something that goes way beyond the techniques that are shown today. It has more to do with respecting tissues that deserve being respected and deserve being left alone. I've done a lot of surgery with my neurosurgical colleague doing pituitary surgery and resecting skull-based tumors. And one thing he said early on, in neurosurgery, in open brain surgery, there is no sightseeing. Don't go places in the brain where you don't need to go. You don't want to touch structures where you that don't need to be touched, that should not be touched. And I sort of copied that from a rhinoplasty approach too. Basically leaving the tissues alone if I can achieve the goal that I've agreed upon with my patient without bluntly saying pulling everything apart, not opening up the nasal tip if I don't have to. And in almost all the cases I operate on, I very well get away with that. So I'm not cutting corners. I'm just trying to respect tissues and not do more, not dissect more than I need to. So it's basically hiding the excess and restricting the dissection of the tissues to the minimum I can afford, or the minimum that gets me to where I want to be with a patient.
So, you know, for me, I find it frustrating that people want to put people in different camps and say, I'm an endonasal surgeon, I'm an open approach surgeon. I think, you know, we should have mutual respect for each other. And at the end of the day, what's going to be best for that specific patient, you know? I think possibly the reason why people are scared, if you want to say it, about endonasal work is the preconceived ideas. I can't actually see what I'm doing. But I mean, yourself and Holger and these guys have shown us that you can get astounding results through endonasal approaches.
I agree. I think the point is that you have to imagine what you do will look like. Number one, I'm speaking about the tip. On the other hand, if you open a nose and you modify your structures, you modify the shape, you reposition your cartilage, you add or you subtract, it's a lot more difficult to see on the table what this will do to the nose. If I do let's say, if I approach both domes with a double dome suture, I see what I'm doing. Of course, there is swelling. Of course, there's a little seroma and hematoma in the nose when you do that, but still, you can anticipate that. And I think that is something that scares a lot of surgeons, because they think what you're doing is below the water surface. It's under the surface. You just basically feel it, but you can't see it. And that is intimidating. Now, the other thing that I've seen is that those who are trained in open surgery, so the external approach, find it very difficult to find their way back, because they think that they have to see what they're doing in order to be secure. Now, I can tell you, and you probably have seen the same, I've seen a lot of collateral damage in noses that were opened, where the surgeon failed to reassemble the nasal tip as it was before. Patients, young women who had a perfectly okay nasal tip that just did not look right after surgery. So basically a collateral damage of the approach. Now, I have my own collateral damages with the techniques I use, but I think it's particularly cumbersome and sorry if you basically damage intact structures that leave a visible stigma of surgery and that is avoidable.
Yeah. So a question in terms of the listeners around the world who kind of want to pursue this and really spend a bit more time looking at how can they get those skills under their belt? What are some of the resources you would advise people to turn to?
Well, I think the first and most important thing is to reflect on what you do, to build upon endonasal techniques you know. For instance, septoplasty is typically an endonasal approach. Very few surgeons open the nose just to the septum. You can, but you don't need to. And move from there. Number two, probably go see surgeons who do that. And just understand that it is doable. You can do it. It's maybe technically challenging, and then find out for yourself, is this something I want to get into? Do I think my hands can do that? My brain can do that? My brain-hand axis is able to manage that? And if so, start probably with less challenging cases and gain confidence, and then move from there. I'm aware that there is not a lot of teaching institutions that still offer that. But there are, and they're good. And the endonasal webinars Holger and I have been organizing for a while now just show that there's an interest due to the substantial number of participants. I mean, I thought we'd do this a couple of times and then interest may fade. That's not the case. So we're very encouraged to see that a lot of colleagues still log on and log in and are part of this and discuss it with us.
No, it's been a fantastic series. So for those of you who haven't logged in, maybe you can tell the listeners where they will be able to find that, on which website.
It's on Facial Plastic Surgery EU. It's if you Google facial plastic surgery EU or Finesse, Holger has hosted it on his website, so that's relatively easy to find, and we'd be happy to take anyone on our mailing list, and everyone's welcome.
Well, that's awesome. Thank you. Slightly changing the topic now. I know you've been very involved over the years with facial plastic surgery education. How do you manage to weigh up between operating and also your time you spend on education and publishing papers and writing chapters and books, etc.?
Well, it almost comes naturally if you document what you're doing. I've always been fond of photography. I'm not a video filmer much compared to photography. And I have the resources within our OR to have someone stand there and take good pictures. Now, that is extremely valuable to reflect. I have my patients come back, I'll look at the outcome, and if I have intraoperative pictures, that is just a fantastic way to learn, basically to learn and see what am I doing, were my concepts right, do I have to change this, have I not done enough, have I been too aggressive, or have I just made mistakes? And I make my fair share of mistakes myself, and I'm always very happy to see what went wrong. Luckily enough, over the years, the mistakes you make become less important. They're not, I see them, patients very often don't even notice that. But I think that's a very important point. The other point you allude to is the question of how can we teach and how can we basically bring young surgeons to the point of where they feel confident. That's a difficult one. I've been involved in teaching in the European Academy for many years. We set up or improved the fellowship program that had been around. We just launched a fellowship program at the Rhinoplasty Society Europe that is now on for about, I think, a month or two. Two handful of applications have come in. So there is a big interest, but in the end, what counts is, number one, passion. Number two, good hands. Number three, the interest, the commitment, and go see people. And number four, maybe most important, having a workplace where you can do and evolve in your surgery, where you can do the cases. I see a lot of colleagues who come to see me and say, well, I don't have the opportunity to do a large number of cases, and I think that is key. Everybody will make some minor mistakes, I think, hopefully not major mistakes, and over time and with increasing numbers of patients, that becomes less of an issue. But it's still a point, and well, basically, I talked to Heinz. I asked Heinz Stamberger, Professor Stamberger from Graz, who is deceased now, how he approaches the issue of teaching in sinus surgery. And he said to me that he had a large number of fellows who went through his program, and he said they were all very decent sinus surgeons, but there's only a handful that I would have liked to do surgery on me. And I said, so would the others have been unsafe? He said, no, absolutely not. They were good surgeons, but in some I saw just a particular talent, a specific talent that made me very confident and say, I like the way those hands move. Now, I think that is something you have to consider for rhinoplasty too. So it's not just the exposure, not just the places you've gone to see surgery. I think it's also the opportunity to do the surgery, be passionate about it, and probably have a little talent.
Sure. That's a lot of things to think about there. Tell me, When have been the really hard times for you in your career? What are the times where you've kind of doubted yourself, or it's been the low points before we speak about the high points?
Low points were probably when I thought I understood rhinoplasty and I saw the not so good outcomes after a year, 2 or 3 doing rhinoplasty. And I thought, now I understood it. I had read all the important textbooks. I had my own operating table. I was basically free to do as I liked. And I fell into the trap of basically doing a cookie cutter approach to most nasal problems, which included cephalic trimming, which included sutures, etc., and realized that a lot of times I over-rotated tips and basically overdid surgery. Now, the sad thing with that is that you see those patients come back after 2 or 3 months, they look terrific and are very happy, and you see them come back after a year, 2 or 3, and you realize that there's something off in the concept you had. So those were drawbacks, basically, early on in doing rhinoplasty. And that has made me more cautious and not more aggressive in the sense of doing more, adding more, or deleting more, but being more prudent in my approach to the problem, number one, and more prudent in the way I handle tissues and change what I'm at, to the point of not offering a patient a textbook nose, as you can find it, or a glossy magazine nose. Some patients do that. They come and show me, I would like my nose like this. And I 180, I flip that around and say, let's start with your nose. And what bothers you? And the next question is this a family nose? Who has that nose in your family? And sometimes, like 2 days ago, the answer is my grandmother. And then I asked, so do you like her? Do you like your grandmother? And when she says, it was a female patient that said, she's the most wonderful person on this planet. I said, no, look, you carry a piece of the most wonderful person on this planet in your face. Oh, doctor, I never thought about it like that. That is a new thought. And I said, well, then why not reflect on if we basically improve the shape of your nose, but we respect the love of your grandmother and the specific shape you have. Doing so, I very often, more often than not, come to an understanding with a patient that it will do less to the nose than would be generally accepted. Then you walk out and say, oh, I thought you would tell me that everything has to be redone because I went to see another doctor and he said, we need to do this and this and this. And I said, no, we came to an agreement that this is the nose you like as we did the simulation on the screen. And very often that is less than what the patient thought, and very often much less than I thought the patient would be requesting. So bluntly, I probably quite often undercorrect issues. Now that makes it very difficult to show these patients at conferences, because then the question is, what did you do? Could you do a better job? You could have fixed this nose, couldn't you? And then I say, no, this was specifically the agreement with the patient. A lot of them end up under local anesthesia in a 15 or 20 minute procedure, just correcting a small issue they have. And I tell them, if they're not happy, they can come back. We can do more than that. But most of them, they stay happy because they understand and they incorporate the concept that was the basis for the informed consent.
So when you're seeing a patient for the first time, how much time are you spending on the history and the examination and the special examinations, testing the airflow, etc., like that? On average, how much time are you doing pre-surgery with the patient?
Well, I have the luxury of having half an hour for first consultations. Most of the patients are referred to me by ENT specialists or by plastic surgeons if it comes to noses. So the first consultation is half an hour. Most of the time, that's just right. That's just right. I don't do airway testing as a routine. Why? Because it's not reproducible. I mean, the validity of these measurements, be it acoustic rhinometry or rhinomanometry or even numeric simulation, airflow simulation, they are not reproducible. They do not correlate well with the complaints of the patient. So I think they're overestimated in their role. I don't base my indication on rhinomanometry. I used to for decades, but I don't do that any longer because the return on investment for a acoustic rhinometry or a rhinomanometry in my eyes is not sufficient. I do the endoscopy, I talk to the patient, and by doing so, I learn if this is the breathing issue, if they have one, is more one of, let's say, a septal deviation, a fixed one-sided issue, or if it's bilateral and changing, then it's probably more a mucosal issue, and then I treat the mucosa first. So I have a large number of patients who primarily come for breathing issues, and I'm very prudent to really sort that out. What I don't overlook and try not to overlook is the issue of anxiety and hyperventilation, which is present in quite a significant number of our patients. And the typical question to elucidate that is pointing to the throat and asking if your nose becomes obstructed. Do you sometimes have a tight throat too, and maybe a tight chest? And if the next question, if it makes them nervous, is also answered with the yes, then we're on a track. Then I give them a questionnaire which looks at generalized anxiety and hyperventilation. So I really sort those out. And if that's a candidate where I find a clue indicating hyperventilation or anxiety, that's something I talk to them about before I even consider talking about surgery.
And with your background as rhinology as well, I mean, Prof. Stamberger had such an influence around the world and even in South Africa. In terms of cone beam CT scans of the nose and paranasal sinuses, how much do you incorporate that into your practice?
Well, the CT scan for me is not necessarily diagnostic first. It is more a planning or a guide or a roadmap for surgery if I plan an nasal sinus surgery. Typically, the complaints of the patient history in combination with a thorough endoscopy of the middle meatus is, for me, most of the time sufficient. Now, when in doubt, for instance, a recurrent ventilation issue of the frontal sinus, Barrow phenomenon, pain with increasing pressure landing in the airplane, for instance, then I want a CT or a cone beam, both are good, to look at the nasal frontal duct if there's an obstruction there. And if the history is typical, that will be a candidate for me to open the frontal sinus. Otherwise, if we liberally use CT and X-ray, what we will find is mucosal swelling, cysts in the recess of the maxillary sinus, opacification of single ethmoidal cells without any clinical relevance. Yeah. So I always compare the CT finding if patients come in with a CT or if I decide to make one or have one with the complaints of the patient and the endoscopic findings. Now, for the typical rhinoplasty, I know there's a lot of colleagues out there who insist on having a cone beam CT before they plan their surgery. I don't. I just don't, because I see what the cartilage issue is and what the bone issue is, either beforehand or during the procedure, and I don't gain any additional value from a cone beam CT.
Okay, so now if we look at it, so you've seen the patient, you spent half an hour, you might have ended up doing CT, really necessary. Most of the patients have been referred. What percentage of patients who actually end up walking across the door to your consulting rooms do you end up actually operating?
At most 4 out of 5, probably. It depends. If we are speaking about a rhinoplasty, so not pure functional surgery. As I said, many patients are referred to me. Some is word of mouth, but a lot of them are referred from other corners of the country, and a large percentage of what I do is revision. So in those cases, it's almost 100% that I end up doing something, very often something minor, rasping down an irregularity, adding a little bit of volume here, rotating the tip a little more, making the patients understand that the initial idea of a beautiful nose is probably not something worth striving for or chasing. because we may end up causing more issues than before. So I have to talk to them and get them to have realistic expectations. Again, my practice is a little bit distorted or skewed by the reference patterns of the patients. A lot of them come to see me because they know that we have a specific approach. It's present. We had a campaign here within Switzerland where we advocated our approach to rhinoplasty. A lot of patients appreciate that and say, I like the concept of not having a scar, but that's not the point. I like the concept of not having my nose being taken apart and then being reassembled if that can be avoided. So I'd say probably 4 out of 5 end up being operated. For purely functional problems, it's a lot less. It's a lot less. So I've learned to be a lot more restrictive with using the knife and doing more of a history and medical therapy in nasal obstruction.
Okay, so I've got 2 more kind of topics I want to chat about. The one is the future of rhinoplasty, and the second one is Abel-Jan's funniest moment in theatre. So perhaps whilst you think about the funny moment, if you were to look to where rhinoplasty is going in the next decade or 2, where do you think we're going to be?
That's an interesting question. I could very well imagine that the pendulum will swing back from very elaborate, long cases to maybe patient-centered and problem-specific smaller approaches. So maybe what some would call an undercorrection or a partial correction of an issue could become socially acceptable. I was in Versailles a couple of years ago at the Rhinoplasty Society Europe conference. Very impressive event. The lecture hall was packed. World-class lectures. It was very, very good. And people no one left the lecture hall because it was so good, but there were talks and presentations on, let's say, alar rim grafting, with 10 or 15 minutes talk on alar rim grafting with very minimal, if any, difference to be seen from the pictures. And I wondered if this will change over time and patients or surgeons may come back to the point of thinking, well, you know, what's the point in doing this or that if it doesn't really change much? And number 2, a lot of these elaborate steps are performed in order to prevent complications or bad outcome. Let's say mid-vault collapse or alar retraction or recurrent deviation or visible irregularities under the dorsal skin, etc. And that is true. But I think that's a consequence, too, of basically making it a big procedure. I mean, if I don't resect the alar cartilage, if I do no or very, very, very limited cephalic trimming, the alar margin is probably not going to retract. If I leave the dorsum intact by either lowering it as it is or maybe even using a rasp, talking to the patient and saying, you know, if I rasp this, I will leave the integrity of your dorsum anatomically intact. There may be a little residual hump. Yes, would you be happy to have that? And a lot of patients say yes. So I could imagine that, let's say, maybe 5 or 10 or 15 years, the pendulum will have swung back to honoring time-tested, simpler procedures. And I could imagine that the public at large will appreciate avoiding a surgical look. And that's what I see happen here. I do simulations on all patients. I change the shape, no matter what I do. Always do simulations, and I always, if the patients ask for it, do an over correction on the screen. I say, this would be textbook. Is that still you? And they say, doctor, I don't know. And then I say, you know, if you sit in a cafe with a nose like this, someone has the slightest idea about rhinoplasty, will see your profile and will think, okay, that's a done nose. And then they say, oh, no, well, that's not what I like. Then I say the alternative is respecting the shape you have now, improving it, making it nicer, but keeping it natural. that will not change your character or the way you look, and people will not think that you have had no surgery. And surprisingly large percentage of my patients or candidates say yes, that's a concept I like. Not to speak of the grandmother example I just mentioned, of the deformity being having a positive connotation because being ethnically or familial.
Wow. Jeez. Abel-Jan, you've been giving all these pearls of wisdom that have been coming down. End it off with us. I want to hear a funny story of what happens in the sometimes perceived the serious Switzerland. Doesn't have to be about rhinoplasty.
You should have given me that clue before, because it's always charming, it's always pleasant in the operating theater, and well, it's typically a very, very amicable and pleasant atmosphere. I'm not sure if something should be very funny. The things we talk about, the stories we tell each other are funny. I must say that I've seen many interesting things happen in the operating theater. I've seen many interesting and challenging and fascinating deformities. I couldn't call them funny though. So if you ask me for a funny story from the operating theater, there's a lot of small little funny things, but the story I think I have to.
Okay. Wow. Well, thanks, man. That brings us to the end of another episode of the Rhinoplasty Podcast. And Abel-Jan, on behalf of all the listeners around the world, people who are watching on YouTube or downloading on various podcast streams, thank you so much for taking time out of your busy day. And thank you for what you're doing for endonasal rhinoplasty and just rhinoplasty education. I think often you guys don't realize what you've done with setting up the fellowships and the work you've done. So from my side, I just want to say thank you. And on behalf of all our listeners, and to the listeners, please come back again next week as we carry on this month of April. We'll be learning all about endonasal rhinoplasty.
Thanks, Cameron. Thanks. It was a pleasure.